And so we're going to start off today with our CAMH land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia, lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. And today, Toronto is covered by the Toronto Purchase Treaty Number 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. And so we'd also like to encourage everyone to introduce themselves in the chat and to share with us the land you're joining us from today. And if you don't know, I'm going to put the link in the chat right now that people can use to find out. And with that, you're also welcome to share something that you're currently doing to learn or improve your commitment to reconciliation. So while people are doing that, I'll introduce myself. My name is Rachel. I am a second-generation Canadian located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty 13. And I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So I can see people are introducing themselves in the chat. We love that, and you're welcome to continue. I'm just gonna keep going with a few other housekeeping items before we get started. So this is just a reminder, if you are interested in receiving a letter of completion for attending this round, to make sure that you registered for the webinar and completed the full pre-learning assessment. Also to make sure you signed into the webinar using your first name and your last name, because that will help us identify you. And also to complete the evaluation and post-learning assessment. And both of those will be sent out to you if you registered at the end of this webinar. And so now, as a bit more about our presenters today. So first we have Alexandra. Alex holds a Master of Social Work from the University of Strathclyde in Scotland, following a BA in Psychology from TMU. Her experience spans national and international settings, including work throughout the Scottish criminal justice system, case management, and private practice counseling. Alex is currently a social worker at our Intrepid Lab, nicotine dependence clinic, where she provides trauma-informed care through comprehensive assessment, individualized treatment planning, group facilitation, and individual counseling using motivational interviewing, cognitive behavioral therapy, and dialectical behavior therapy. So welcome, Alex. Thank you for joining us today. And I'll give you a moment to read through Alex's disclosures. And our second presenter is Dr. Osnat Melamed, and Dr. Melamed is a clinician scientist in the Campbell Family Health Research Institute and a staff addiction physician at CAMH. She is also an associate professor in the Department of Family and Community Medicine at U of T, where she holds the 2023 New Investigator Award. Dr. Melamed is an early career investigator with research interests in tobacco addiction and the intersections between substance use, mental health, and gender. Dr. Melamed is interested in the use of technology for the delivery of treatment for substance addiction. She develops innovative digital health tools such as smartphone apps and AI-based chatbots to support individuals in quitting smoking. Welcome as well. We're excited to have you both. And I'll give you a moment as well just to read through Osnat's disclosures. And this is just a note that all eligible Teach Educational Rounds presenters are offered an honorarium. But that being said, presentation content is not affected by acceptance of this honorarium. And also make note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources: These materials, as well as their verbal presentation or any discussion, are representing of only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare providers. And so with that, I'll pass it along to the both of you to get started. Thank you so much for coming today, and we're excited to hear your presentation.
Thank you so much, Rachel, for your kind introduction. My name is Osnat Melamed. I'm really excited to see so many attendees join us today for this session. So thank you all for joining and for the opportunity to present with you today some of the work that we've been doing specifically on women with diabetes and quitting smoking. And thank you so much, Alex, for being my co-host for today. Okay, so we'll start with the learning objectives for today. So we have a couple of them. The first one is talking about why is it that women have a greater difficulty in quitting smoking compared to men. And we'll see that there are a couple of reasons that we could name that could explain this difference. And after we review that, we would want to say why or what interventions, given that we know that there are differences and difficulties that are found among women, what are some of the interventions that are suggested in the literature that could help women be more successful in quitting smoking? And I brought in this infographic on the right to show that this one is taken from Australia, that, for example, this is some promotional materials for women who encourages them to quit smoking. And it is tailored specifically both to sex and gender. So you can see here that one of the reasons that women are prompted to quit smoking is because they're going to have better pregnancy outcomes. So talking about that reproductive health. And the second thing is it says that after quitting in 1 month, your skin appearance is likely to improve. So there again, we have a gendered approach. Potentially men will not be as receptive to this or will not encourage them as much, but for many women do find it encouraging. So we can see how sex and gender is being kind of put into messaging for women with regard to quitting smoking. And then our last learning objective would be to talk about, okay, so we have this knowledge that women have a greater time quitting smoking. We know what are some of the things that could help women overcome those challenges. And the last part would be how we used this information to create educational materials specifically for women who have diabetes. Okay, so there's just a bit of a lag here with the slides. Okay, got it. So I think that, there's some slides, I don't know, maybe that are missing because I think we had a few others, but we can just kind of talk a little bit about some of the sex differences in the health effects of smoking. So we do know that even though the cigarettes are the same, there isn't, men and women don't smoke usually different cigarettes, but the same cigarettes. We do know that women smokers face a greater risk, health risk, compared to men who smoke. And this is true even for the same amount, meaning that if a woman were to smoke a pack a day, same pack a day as a man, the woman is likely to show greater physical health problems even though they're smoking the same amount. And I think many agree that one of the main reasons for this is that the physiological differences, mainly in body size. Women are smaller. They don't have a smaller cigarette usually to smoke, but they are smaller, which means that there is greater toxicant exposure. And there could be other physiological differences that are related to metabolism and hormonal changes, for example. And we brought just a couple of those major health risks that we can see a difference. For example, lung cancer. We all know that smoking is very closely correlated with lung cancer. And we see that women have a greater risk of lung cancer compared to men, given the same lifetime smoking exposure. Another thing that we could talk about with regard to COPD is that when women smoke and they're diagnosed with COPD, we usually see a greater reduction in the lung function over time compared to men. Therefore, the urgency to quit smoking, especially when they're giving that diagnosis, because it's going to progress quicker, potentially. And another thing is coronary events such as heart attacks or strokes. So women who smoke have a 25% greater risk of having those events compared to men. So these are just a few examples of the harms of smoking, obviously present in men who smoke as well, but in women, those are higher usually. What about reasons for smoking? Or is it different between men and women? So from the literature, we do know that more women tell us that they smoke in order to control their weight, relying on the appetite suppressant effect of nicotine. So if I'm hungry and I have a cigarette, I may be able to skip lunch or skip dinner and just consume less food overall. That helps me maintain a lower weight. And in fact, some of the studies that are done among girls and young women who started to smoke, so many of them mentioned that they actually started to smoke in order to control their weight. So the group that started to smoke tend to be a bit more overweight compared to those who didn't start to smoke. And another thing that's considered unique about smoking among women is the fact that many women tell us that the reason they smoke is that they use smoking to cope with stress or different unpleasant emotions that they have. It could be low mood, it could be anxiety, panic, other things that are bothering them. And we know that that's more common among women than men. We also know that when women want to quit smoking, they might face unique barriers to quitting smoking. And one of the things that we hear, and I know, Alex, you'll be adding a bit more about that in your part, is that women come to us, they want to quit smoking. We see them in the clinic, and then we ask, well, who's supporting you in this quit? And, they might think for a minute and say, really, I have no one that's rooting for me, no one on my team. I don't think that my partner wants me to quit or cares if I quit. Or maybe the opposite, maybe, they don't want me even to quit because, then he won't be allowed to smoke inside the home, for example. So I don't have people who are supporting me, and we all know that social support is so critical for quitting. And the second point, it's just something that we just touched upon with regard to, we also know that if a woman has a smoking partner that's a man, she's less likely to be able to quit because of the smoking partner. And the interesting thing is that this doesn't go the other way around. So if a man has a woman that's a smoking partner, we don't see the men struggling to quit, but we do see that if the woman has a smoking partner. And the last part here is also something that we talked about as a reason for smoking, to coping with stress or to deal with unpleasant emotions. And we also know that women do tell us that they have, it's more prevalent for women to tell us that they have depression, they had domestic violence, experiences of domestic violence or trauma, or sometimes power dynamics within the home it can make things more difficult or stressful for them. And then if I rely on my cigarettes to cope with those things, it's just going to be much harder to give that up, because a lot of the times I feel that the cigarettes are what helps me get through the day or get through this tough period. We also wanted to talk about quit intention and quit success. So, despite those challenges that women tell us, we know that they're just as likely as men to want to quit smoking and attempt to quit smoking. But what we do see is that women are less successful. So they may try just the same as men, but they're not as successful. And there is some research to say that, when we have a group of people who are trying to quit smoking, we saw that women tended to relapse quicker. So potentially they could be quit for a couple of days, but then they went back to smoking. And they had overall 31% lower odds of succeeding in quitting compared to the men. So wanting to quit smoking, maybe even being able to be quit for a little bit, but quickly relapsing, that's more common among women than men. And this is some data that we have from our own STOP program. And I know that many of you on the call are working within STOP. So what this investigation or this study wanted to actually check is, we have a lot of people who are enrolling in STOP each year. And let's look whether the men and the women are equally successful. And what this study or investigation found was actually that there was a 16% difference, or in the odds of quitting, 16% less likely among women, and this could not be explained by any other variable. So it's not that the women were heavier smokers or had mental health issues or something that could explain the difference. This is after controlling for all the potential differences that we are aware of. And what we found is that the quit rates for the women were 24% at the 6-month mark at the end of the program, and men, had 27%. I mean, it doesn't sound like a huge difference, but in clinic, that would mean that for all, every 100 people that come to us, 100 men, 100 women, only 24 women would be able to quit, whereas 27 men would be able to quit. So like 3 women, just because something related to their sex or gender, made it harder for them to quit smoking. And those 3 women, it's kind of a clinically meaningful number. So definitely a lot of the work that we do is trying to address this gap. How could we explain this gap? So one of the things that we are aware is that smoking cessation medications, and in this particular graph, you can see the 3 approved medications, varenicline or Champix. TN is transdermal nicotine or the patch, and bupropion or Zyban. So I think this network meta-analysis that was published in 2017 found something very interesting. It found that actually these smoking cessation medications, when you look at men compared to women, so for men, they're equally effective, varying slightly higher, but kind of no statistical difference, which means that if I give a man, Zyban, varenicline, or nicotine patch, they're more likely to do well with all 3 of them, equally well. And this is not the case for women. So what you can see is in women, there is one bar that's really tall, which is the varenicline or Champix, whereas the Zyban and the nicotine patch are much lower. So actually, we know that varenicline is probably should be the drug of choice for smoking cessation for women, because women just respond better to it. It was kind of 41% more effective than patch and 38% more effective than bupropion. So, and this is probably related to different both sex and gender issues. So, and in our STOP program, as you know, we do give people the patch, so that could be maybe partly explain the reason. We also know that men and women have different quit experiences. Women usually tell us that they're having more withdrawal symptoms. They can count a greater number of withdrawal symptoms, and they rate their severity as higher compared to men who are given the same scales to report. And this also maybe explains why when women and men try to quit in a cold turkey, meaning they're not taking any smoking cessation medication, women have much lower success compared to men, because if the medications help sort of curb those withdrawal symptoms, if I take a medication, I'm much more likely to succeed. But then for men, maybe my withdrawal symptoms are not as high, or I'm better able to tolerate them. And even when I do a cold turkey quit attempt, I'm successful. But for women, it doesn't seem to be like a good strategy. And this is, of course, just kind of talking about what you're all very familiar with and here on your day-to-day practice, kind of the nicotine withdrawal. Women a lot of times focus on the emotional, sort of I'm irritable, I'm anxious, I'm depressed, very hard for me to concentrate. Maybe I feel fatigued, sometimes, constipation, sleep issues. So definitely if I have a lot of those and I rate them at kind of a high severity, it's really going to be hard for me to not go back to smoking. And we did talk about maybe I'm able to kind of go for a day or two or maybe a week, but then I just sort of cave in because I'm very irritable, for example. Another point that we wanted to talk about with regard to sex and gender differences and the quit experience, that's related for women in their childbearing ages with a menstrual cycle. And we do know that women have different levels or fluctuations in the hormonal levels throughout the menstrual cycle. And what you can see here is that we have the follicular phase, which is the beginning of the month, like day 1 to 14. And then we have a switch to the luteal phase, which is post-ovulation from day 14 to 28. And what you can see is the follicular phase, we just have a kind of the purple line is just increasing, which is the increase in the levels of estrogen. So usually in that time of the month, women have a bit of an easier time quitting because there is, lower withdrawal symptoms when they try to quit at that time. Whereas in the luteal phase, as you can see, there are fluctuations. The estrogen levels go down and then they go up a little bit, and the estrogen level, the progesterone in yellow is going up. So there are more fluctuations that could be potentially one of the reasons why women have greater withdrawal symptoms. It could be related to those fluctuations and maybe less success. But I think, the jury is still out there with regard to timing of the quit to the menstrual cycle. That we have an ongoing study with regard to that, because some studies showed that there's better success in the luteal, in the follicular phase, and lower success in the luteal phase, but some others have not replicated it. So I think the jury is still out there, but which could mean that maybe some women do experience this, but not all women. Yeah, so I think, this is, if we want to summarize and kind of preparing for Alex to take over. So we talked a little bit about why women have a greater difficulty in quitting smoking. We talked about the sex and gender related factors, if it's biological. We saw the hormonal fluctuations. We also know different medications have different effectiveness. We talked about the psychosocial, if it's stress or lack of support. And, potentially if we have those smoking cessation interventions, if they address the sex and gender related factors that could help more women quit successfully. Our talk today is not just about women who smoke, but particularly about a subset of this group is women with diabetes. And we see them in our clinic quite often. The reason for that is because a lot of the patients, I see, Alex sees, and you see in your clinics, a lot of them are older women. And we do know that the prevalence of diabetes increases with age. And so we see, many women in their 50s, 60s, and 70s. By that time, they've developed diabetes, so that's not uncommon. Diabetes is quite a common condition. About 10% of the population has diabetes. So it's not uncommon for us to encounter a woman that's smoking, comes to us for treatment, but also has diabetes. So one of the things we wanted to say, kind of why did we focus specifically on this group? Why did we kind of choose women with diabetes specifically? So one of the things we know that the combination of smoking and diabetes is not a good one. We can call it a double whammy. And I brought in this, this study that looked into what happens to people who have diabetes who smoke. So this was a meta-analysis of observational studies. So what they do is quite simple, the methodology. They enrolled a group of people who have diabetes. They were all kind of healthy at baseline. Apart from the diabetes, they did not have any heart problems or strokes or things like that. And what they did is they followed them over time, and they wanted to know whether they would develop later a heart attack or a stroke or any, whether they would die over the course of the follow-up period. And what they did at the end is kind of look into those outcomes, those health outcomes among the people with diabetes. They compared people who were smoking in this group and people who are not smoking. So all of them had diabetes, but some were smoking and some were not. And they wanted to see whether there are differences in the health outcomes. So the results were quite, astounding with regard to how much this combination of smoking and diabetes is not a good combination. And for example, when they looked into the heart attacks or myocardial infarction, they saw that the group, so again, just all of these were people with diabetes, but the group of people that are smoking had a 52% increase in the risk of having a heart attack, which is, a big increase. And pretty much similar results for stroke. Again, another unfavorable outcome, 44%. And you can see kind of all the studies that looked into this. And the overall mortality was also, 48% increase in mortality. So I think, and this study was already published in 2013. And, I guess additional studies would just kind of say the same thing, that it's quite, the combination of smoking and diabetes is not a good combination, increases the risk substantially for adverse health events. And we just talked about kind of the double whammy, right, of having smoking and diabetes. But I think if we kind of link it to what we started to talk about is, how women have challenges, what we kind of see is that we have a group that's sort of a sizable group that actually has quite a lot of health risks from different, because of different things, right? So because I'm a woman, I have those sex and gender related challenges to quitting that we just talked about. Because I have diabetes, probably, my vessels have damage and are more likely to lead to a heart attack or a stroke. And that's in combination with the smoking. So we can kind of see that we have this triple whammy of, a woman with diabetes who is smoking. And I think this is, Alex, where I hand it over to you. So this slide just comes to put the rationale for why we chose this group to kind of focus our research on. And I think that, so I'll just finish this slide, Alex, and hand it over to you. So I think in this study, what we did is, look into what are some of at the first phases, just to look at what are some of the programs that are specifically unique to women that are found in the literature. So we kind of scanned the literature to see which smoking cessation programs were tailored to women and what was it in this program that was meant to help women quit smoking. And once we kind of got an understanding of what might those interventions for women, what might they be, we wanted to adapt it to women with diabetes. And once we adapted it sort of in a consultation, co-design manner, what we wanted to do is create some educational materials that we'll share in a bit to, one of them that could potentially help women with diabetes quit. So thanks so much. And I think, Alex, this is where we hand it over to you.
Okay, thank you, Osnat. I'll just take control here. Okay. Oh, sorry, Rachel, can you share the PowerPoint again?
Yeah, no worries.
Yeah.
I'll pull it back up. And then let me just go. I might not remember where it was.
Yeah,
so
I think it was slide 33.
33, okay. 33, and then I think, do you see the take control button still?
Yes.
Okay, perfect.
Okay, perfect. So let's talk a little bit more in depth about the current study. So this was done obviously to explore the additional risks that women with diabetes face when they're smoking. So as we've discussed, we know that women face much greater harms from smoking compared to men, and it's a lot harder for women to quit compared to men. And we'll go into this in more depth as well. So for clinicians, when we're working with clients that are trying to quit smoking, sometimes we fall into the trap of using that like one-size-fits-all approach to treatment. But the study helps us to realize that women who have diabetes do need those additional supports from us. If we have a female client that's sitting across from us in our clinic, they do face these additional challenges to quitting smoking, and we know that this translates to lower successes and higher risk of health complications for them, unfortunately. So today, next, we're going to talk a little bit more about how to tailor our treatment to this demographic based on the literature. Okay, so for phase one here, phase one of the literature review really helped us to understand what was already out there for women with diabetes that are trying to quit smoking. So what programs? The majority of women-only smoking cessation programs did focus on those who are pregnant. However, the search came up with about 25 unique programs for our current demographic. And these programs offered support, like social support for quitting smoking. They addressed those concerns over weight gain, and they aim to strengthen coping skills for stress, anxiety, and low mood. The literature review aspect of the study was super important because it kind of acts as a starting point for identifying like what the programs were that were already out there and how we can use the knowledge to tailor it towards our demographic of women with diabetes. So let's look at the findings now. So the first major finding from the review was the importance of increasing social support for women during their quit journey. So like Osnat had said, a lot of women clients come into our clinic and they lack that social support. There's no one in their corner when they're trying to quit smoking. So one of the strategies at the bottom that was mentioned was community campaigns. So this could be making sure the overall community is more aligned with having a smoke-free environment. Now, if we reduce smoking accessibility in our environment, it makes it a lot easier for women to initiate and succeed in their quit journeys. So this is key here. It's a lot harder for women to exercise assertiveness when it's not a smoke-free environment. And I'll share an example to provide some context for what I mean. I have a client, she lives in a government housing building where a lot of folks smoke in their units there in this particular building. So she's doing really well. She's trying to quit smoking. She's taking a lot of steps, but she's running into this pushback of making a smoke-free policy in her home. She has a lot of like friends and family come over, they're smokers. She's trying to ask them to go outside to respect her boundaries, but they say, you know, everyone in this building smokes inside. It's cold outside. Like, we want to smoke inside too. So this is just an issue that she's been running into. And counseling here really helps to kind of help clients negotiate these boundaries with their loved ones and encourage like advocating for that smoke-free policy. Research also shows that women benefit from counseling just to talk about how to navigate these kinds of situations that may involve conflict or negotiation with other people. We can help our clients maybe by using like gentle motivational interviewing or solution-focused therapies to discuss these like case-by-case situations with them and make them feel more comfortable to advocate for themselves. At KMH here as well, we do model this smoke-free environment initiative since we're a smoke-free hospital. And we obviously have our nicotine dependence clinic here for screening and nicotine cessation treatment. And many of our staff within the hospital are also trained as well with screening. Okay, so moving along to result number 2. We've talked a lot about the post-cessation weight gain. It's a major concern, it's well documented, and it's a sex and gender barrier that women face here. So women face a stronger societal pressure to maintain being thin in Western culture. There's a greater stigma for weight gain, and there's higher rates of body dissatisfaction and shame in our culture for women. So research consistently shows that women are more likely to smoke to suppress appetite. We've already mentioned this. And it really speaks to the body image dissatisfaction that's way more prevalent among women. So this means that weight gain can often happen when quitting smoking, and it can feel catastrophic, like very catastrophic, when clients start to notice the scale creep up a little bit in those early stages. A number of clients relapse as a form of weight management, and they can fall into that like classic yo-yo effect of quitting, gaining weight, relapsing to suppress appetite, and then so on. One example from one of my clients was that she was amazingly able to quit smoking, which was great. But then she noticed that she was eating more during those stressful times throughout the day at work when she would normally smoke. So essentially, she kind of replaced smoking with eating instead. So she noticed the scale going up and up, and then she ended up relapsing again to feel back in control, more in control of her weight. So luckily, like farther down the line, she was ready to make another quit attempt, which was great. And this time we were able to plan more for those early stages of weight gain and normalize it together. So she was open to working with a physician to use the nicotine replacement therapy that helped limit the weight gain a little bit. And we put in some more like behavioral interventions instead. So she was able to do like lunchtime walks instead of taking a smoke break at lunch. So she was more active. She started using a meditation app, which was very portable for her to bring to work on her phone and use during those stressful moments throughout the day. So that was good. And even though she did notice that she gained a few pounds at first, she was able to reframe her thinking and focus more on the benefits of quitting smoking. So the other thing she was gaining was the better breathing, she was coughing less, and there were fewer glucose spikes as well. So that was good. And she was able to remain smoke-free and just stabilize the weight in the long run. So this kind of speaks to that concept of using behavioral therapy in cognitive behavioral therapy in these instances. So it's such a helpful thing that we can do to try to help clients reframe those weight beliefs and help them to expand on their flexibility and self-compassion during the early stages of the process. So we can help our clients to identify those negative thinking patterns that are more associated with weight gain. For example, like the catastrophic thinking or the all or nothing beliefs, and we can help them to reframe and replace with a more balanced and alternate thought. And then I'll speak to the exercising strategy that's listed. It's so important for women's well-being in general, not just for weight loss. It can help us to manage cravings, mood, and stress. And luckily, we have a number of programs available for free or low cost through like family health teams, community centers, local recreation centers across Ontario. So that's great. But I also want to highlight the importance too of independent exercise as well. So even just going for a walk or, typing yoga into YouTube and seeing what comes up. Walking though, so great, like for women with diabetes to do even like a walk around the block or a 10 to 20-minute walk after a meal, because it does help reduce the post-meal spikes in glucose. So that's good. And it can also serve as an alternative to that post-meal cigarette that our clients often note is a huge craving for them. Okay, so we'll move along here to result number 3. So the last major barrier here to consider is psychological distress. So this can be stress, anxiety, and low mood. And this is integral to talk about because smoking is a learned stress management strategy for many, and it's compounded for women, obviously, by those sex and gender challenges. So some common stressors that we hear from women in our clinic would be like the relationship stress they're going through, caregiving, childcare, financial strain, compounded with also possibly managing diabetes too. So it's a lot. Women are almost 2 times more likely to be diagnosed with depression than men, we know that women are more vulnerable. They face threats like domestic violence, assault, abuse, so on, and they're more likely to be the victims of domestic violence. So, these challenges get in the way of women when they are quitting smoking. Some of the strategies listed on the side here to manage this distress are physical activity, which we've talked about, mindfulness training, and there's a lot of great applications online for coping. We do offer a stress management group at our clinic, at the nicotine clinic here. So it's designed specifically for people who notice that stress is a trigger to smoking. And this group introduces different theories and therapeutic tools to replace smoking with a healthier daily practice to manage their stress. I'll give one last example today. So we did have a client who was a single parent. She has 2 young children, and she also has some caregiving responsibilities as well. So she has a lot on her plate, and she describes smoking as one of the few predictable moments of relief during the day, which we've heard from other clients as well. Like, cigarettes were always there for her. They were a toxic best friend, yet they were there for her in these challenging moments. So the psychological load that she was carrying was such a barrier to her feeling able to start a quit journey. It felt like going up a mountain. But in counseling, we were able to reframe the concept of quitting together and trying to view it more as like gradual and flexible instead. So she was able to work with a physician to start gradually reducing her smoking, and started to use nicotine replacement therapies instead to help with the withdrawal. And then she also joined the stress management group that I spoke about, and she was able to learn different coping strategies to replace some cigarettes with some different healthier practices as well. So over time, she was able to decrease the smoking, and her confidence improved as well as she realized that she could do it despite what she was up against. So empowering to see these examples. But we'll shift back to phase number 2. So the findings that we just discussed, they were also discussed in workshops with researchers, patient partners, and clinicians. And then this fueled the development and co-creation of different knowledge mobilization products. So we'll take a look at one of the products here. This is a snapshot of one of the materials that was developed, and it highlights the double danger that women face of having diabetes and smoking, including those unique health risks. And on the bottom, it flags that quitting smoking is a journey of many, many small pivots and baby steps that create change over time. So it's very important to emphasize this like self-compassionate approach to this demographic of women with diabetes. So one of the key takeaways from the materials was just the need to normalize these additional difficulties that women with diabetes face. A lot of the times they don't realize that, and there's often that narrative of like, what's wrong with me? Why is this so hard for me? My husband or my dad quit smoking cold turkey, but I can't. And it's good to just educate people about all of these other barriers that they're up against. Okay, so another one of the educational materials here, just providing some psychoeducation on understanding nicotine use, the unique impact it has on women's health, normalizing why it's so hard to quit, and encouraging the development of a tailored approach to quitting. And now we are going to watch a short video that was developed in phase 3. So it's an example of a patient-physician interaction here. And I'll pass it back to Rachel.
I'll share. You can both see that? Everyone can see that?
Yes.
Okay.
Hi, Susan. Nice to see you today. Coming in for a diabetes checkup?
Hi, doctor. Yes, I am coming in for a checkup. I've done all my blood work last week. I've also been feeling good. I take my metformin every day. I exercise 3 times a week and eat a very healthy diet.
That's great to hear, Susan. Well done. I see your hemoglobin A1C is in the normal range, and so is your weight. I see in your chart that you indicated that you smoke about 10 cigarettes a day. Can you tell me more about your smoking?
Yes, I've been smoking since high school. Not a lot, maybe 8 or max 10 cigarettes per day.
I see. I wanted to share with you that quitting smoking is one of the best things you can do for your health, particularly since both diabetes and smoking increase the risk for health complications such as heart attacks and stroke. I strongly encourage you to quit. Are you interested in quitting?
Well, I do know that smoking is not good for you, but I did not know that it is even more harmful for people who have diabetes, like me. But quitting is hard. I don't think I can quit smoking.
So, you are concerned about the effects of smoking on your health, especially as a woman with diabetes, but you're not sure you will be able to quit smoking if you wanted. You said quitting is hard. Can you tell me what in your life makes quitting hard for you?
Life throws a lot of things at you, and smoking helps me deal with it. Smoking helps me deal with the stress of my job, with the worries I have about money. It just helps me unwind in the evenings after work.
I see. Many women who smoke feel that cigarettes help them cope with the stress they experience in life. Although the nicotine found in the smoke gives us a temporary feel-good experience, it does not last for long and has no real effects on the stressors we experience in life.
Yes, that's true. Even though I smoke day after day, the stress in my life does not go away. I've tried to stop smoking a few times, and it was really hard. I could not make it last more than 2 days. I felt restless, irritable, moody, and anxious.
Right. You are describing a typical response of the body to the absence of nicotine, especially in the first few days after quitting. It can be challenging to break this cycle on your own.
Is there anything that I can do so I am not so irritable when I stop smoking? Something that can help break this cycle?
Yes. In fact, all of the medications we use for smoking cessation are effective because they do just that. Reduce the intensity of nicotine withdrawal a person feels when they stop or reduce their smoking. Using medication helps people go longer without smoking, cut down, and eventually quit. Counseling can also help you break this cycle by giving you skills to deal with nicotine cravings or urges and develop healthy coping strategies for stress.
That sounds good. Thanks, doctor. I would be interested in learning more about these options.
Sorry, I think it cut off, but let me just jump back to where we were.
Yeah, I think this is where we open it up for questions, right?
Yeah.
This is
Okay.
the end.
Oh, and I guess it's just this was the last slide, which is
Yeah.
acknowledgements, right?
Yeah, just giving a shout out to the members of the team that worked hard on this project. We have our collaborators with Diabetes Action Canada, our research team, and Sophia's and Darrell's voices on the video. So thanks so much. This was a team's work. But yeah, but I guess we can open it up for questions. Yeah.
So yeah, if you're welcome to post any questions in the chat. There were a couple that came up that I'll ask, and there were a couple from the registration form that I wanted to ask you guys. But in the meantime, if anyone has any other questions, please put them in the chat and we'll get to those as well. So the first was, how does smoking cessation affect insulin sensitivity and glycemic control in the short and long term?
Yeah, so thanks very much. It's a wonderful question that we didn't have as much time to expand on in our presentation. So the question is specifically about what happens when a person with diabetes quits smoking. What happens to their glucose control? Does it change? So I think generally what we say to people, especially people who are on insulin, as they quit smoking, we do recommend that they do a more closer monitoring of their glucose levels, tested more often, because there might be fluctuations that are related to some changes now with the absence of nicotine, which increases insulin resistance. So there may be some changes that we need to look out for. So that's usually in the first couple of weeks after people quit smoking, and more specifically for people who are on insulin. And then the other thing that I think is really important, particularly in the context of people with diabetes who quit smoking. So we just talked about how, because I'm no longer smoking, I have an increased appetite. And Alex, you mentioned, people telling us I'm kind of replacing that cigarette that I used to have in my break with eating something when I have a craving that helps me. And then as a result, and we know, by the way, that people tend to reach out to those, palatable goodies. It could be a donut, it could be something sweet, a chocolate, perhaps. And we do know that eventually, especially in the first 3 months after quitting, that leads eventually to weight gain. And particularly if people eat a diet that's kind of high in those sugary processed foods, they do gain weight. And of course, that has an implication for diabetes control. So we would also urge people to look into a more holistic approach, right? Kind of dealing with cravings and urges with other ways apart from eating, trying to minimize those palatable foods, and also focusing on trying to take the advantage of the fact that I'm no longer smoking. I breathe better, to pick up those physical activity and healthy eating, which we actually have good evidence to show that when people quit smoking, their diet improves. They are able to taste better. So fruits and vegetables, more vegetables taste better, and they eat more dairy products. Overall, their quality of the diet improves. So we do want to kind of say, yeah, this is a time when we need to monitor how your glucose is doing. It's really important that you've quit for your health. We're dropping those risks for those adverse cardiovascular events, like heart attacks and strokes. But we do want to be mindful of the fact that eating a lot of unhealthy foods, gaining weight, that would negate some of those benefits. So we would want to kind of do this holistic, virtuous health behavior change, so that one thing leads to the other. So I'm quitting smoking. I'm actually, able to exercise more. I'm able to eat healthy, and just be overall much healthier. So I hope that answered the question.
That's great. Thank you, Osnat. There was another one. This was also from the registration form. And it was, how do experiences differ for women with diabetes who are Indigenous, racialized, low income, or living in rural settings?
Yeah, that's a really good question. I think for Indigenous women, we do have to educate ourselves on those distinctions between commercial tobacco and using it for ceremonial use. So when it's used for like those prayer offerings, giving thanks, opening and closing ceremonies with like elder instruction. So it's a lot different from the commercial tobacco use. And we also have to acknowledge that this population experiences historical and intergenerational trauma that affects their trust in the healthcare system. So that's another acknowledgement there. And many Indigenous women do report that anti-smoking messages fail to distinguish between the commercial tobacco and the ceremonial tobacco use. So I think it's always good to just ask our clients like if they can define it for us and just become informed by their definition and understand their point of view, and just respect their cultural identity and make goals that are realistic to that. So that way they can connect to their culture and their community and their practices when they're quitting smoking. And yeah, I think also it's important to reduce stigma with racialized communities by like naming stigma, acknowledging it, ensuring that you're creating a safe space, building that therapeutic rapport very slowly with people, not rushing the process, and just checking to see that presenting people with options and seeing which way they want to take those options is very empowering, for any demographic. And I think the last demographic was rural communities. So I think we're lucky in a post-COVID world. The one thing we're lucky for is like the increase in virtual care. So for that, I would just encourage people to like lean into looking up those resources that are online too, because we've got so many resources that are online. A lot of our groups at our clinic are virtual too. There's so many helplines as well. So yeah, just tapping into that.
Thank you, Alex. There was another one about when I think it was Osnat referring to nicotine patches as a quit aid, and medication effectiveness. Someone wanted to know if that would include combination NRT with patches and short-acting NRT.
Yeah, thanks very much for this question. I think it's a really good one because we do know that when we add on the short-acting nicotine replacement on top of the patch, which I think is standard practice, when people come for us in stop, we usually provide them with the patch plus one of the short-acting that they choose. We do know that the outcomes are better compared to when people just use the patch alone. So you're right to assume that we had, the data that was presented potentially looked at a less favorable regimen of NRT compared to the combination. And I think your question is, what if combination therapy was offered? Could it be, doing as well as varenicline potentially? So that's a good question. I don't have data to answer that question or research that I'm aware of. But what I would say is that a lot of the times I do hear from women that I'm seeing that varenicline specifically just sort of crushes those cravings. Whereas I don't feel that many women get the same response with the patch. So again, this is not a study. This is my experience in the clinic that there's something about varenicline for women that just reduces those cravings to a greater extent than patches plus, do. So I suspect that there's something unique about varenicline that's more effective for women and maybe even more than the patch plus. But you're right that the results are just for the patch, so I can't say for sure that the patch plus how it does compares to varenicline. But I think it's fair to say that women can start. If I think one of the challenges is that varenicline they have to pay out of pocket, whereas stop we provide it at no cost. I think it's fair to say that many women start with the patch. They might get ahead by cutting back. But if it doesn't do the job, then I think varenicline is a really great option to consider because, it is covered under ODB. So for people in Ontario who have, OW or DSP or old age, it can be covered for them. It's at no cost. But it is, a challenge sometimes also with coverage if I don't have coverage for this medication. Yeah.
Thank you. And then someone wanted to know if there are education resources available for distribution or anything that is being developed.
Yeah, so I guess a lot of the things that we shared with you today we can make available. Those are available for people to use. Absolutely, yeah.
Perfect, thank you. And then I know we're at 1, so if anyone I know might need to head out, that's okay. I think we have time for one more question, but thank you everyone for joining. The last one would be, given the mixed evidence on whether smoking during pregnancy increases the risk of gestational diabetes, how should clinicians and public health programs address smoking cessation, specifically in women at high risk for GDM?
Yeah, so I think that that's true. I think that because nicotine in the cigarette acts as to increase insulin resistance, a woman that's pregnant and is smoking may have an increased risk of gestational diabetes because of that effect. At the same time, I think that I think that smoking throughout pregnancy, the risk of gestational diabetes is just one of a myriad of complications, both for maternal health and for the health of the pregnancy that are at stake here. So I wouldn't, necessarily be just worried about gestational diabetes, but I would be worried about intrauterine growth retardation. I would be worried about preterm birth, low birth weight, potentially cognitive effects in the fetus. So I think that, there are just a lot of other concerns as well. The risk of kind of metabolic complications is one of them, but yeah, definitely. And I guess less studied. I think more for women who are smoking during pregnancy, I think the major concern are more the obstetrical ones like low birth weight, premature birth. I think those are like the big ones that are sort of talked about, but definitely, if I'm at risk at gestational diabetes, that's not going to add to the health of my pregnancy, right? So that might harm me, the baby. Yeah.
Thank you. Thank you both for answering these questions, and thank you again for our presentation. I'm just gonna, wrap up with some final items, but thanks everyone for joining. I understand if anyone needs to leave at this point, we're past 1. But thank you, Osnat, and thank you, Alex. And we have their email on the screen if anyone wanted to reach out with any more questions. Just a couple of last minute items. We'll have our second January tour. This will be a Roberta Ference lecture on therapeutic potential of GLP-1 based therapies for smoking cessation. And registration is now open for that. It will be on January 21st. And registration will be shared with everyone who registered, as well as slides and a recording from today's webinar. And if you missed a portion of today's webinar or would like to view one of our other webinars, we do have an archive list on our website. For now, though, thank you. Thanks, everyone. Thank you, Osnat. Thank you, Alex, for joining, and I hope everyone enjoys the rest of their day.
Thanks very much, Rachel.